agenda, and I am just about to introduce our two guest speakers. And after the doctors go and speak, and we have some questions and answers, then Tiffany Gladney, NC Child's Policy Director, will be providing us with a legislative update, and then we'll be finishing up with announcements and adjourn. So we are honored to have two powerful presenters with us today who are on the forefront of the science when it comes to children and preventing the spread of COVID-19. Both are respected researchers and both serve as advisors to various bodies who are making decisions about these policies, from the CDC and the State Division of Public Health to county health directors and local school boards. Dr. Maria Mayorga is a professor of personalized medicine at NC State University. She is also part of the COVE-SIM team. COVE-SIM is composed of research faculty from North Carolina State University, the University of North Carolina, East Carolina University, and Georgia Tech University. I don't know how Georgia Tech got in there, but no. They are one of the teams chosen nationwide by the Council of State and Territorial Epidemiologists and the CDC to support forecasting, analysis of interventions, and communication with key stakeholders regarding COVID-19. Welcome, Dr. Mayorga, and thanks for being with us. We also have with us Dr. Ibukun Kalu, who is a pediatrician at Duke Health. She is the medical director for pediatric infection prevention at Duke University Medical Center and assistant professor in the Division of Pediatric Infectious Diseases. Dr. Kalu is part of the ABC Science Collaborative. The ABC Science Collaborative pairs scientists and physicians with school and community leaders to help them understand the most current and relevant data about COVID-19 so they may make decisions that will help teachers, staff, and children be safe when they return to the classroom. The Duke University School of Medicine and Duke Clinical Research Institute developed the ABC Science Collaborative in response to COVID-19 and its impact on schooling. Today, Duke and the University of North Carolina School of Medicine are working together to lead the program, which receives its funding from the National Institutes of Health. We are so grateful to both of you for your incredible work and your public service throughout the pandemic. Thank you so much for being here today to share your research with the Child Advocacy Network. Dr. Mayorga, I will hand it over to you first, and then we'll go to Dr. Kalu. Remember, folks, if you have questions anytime, please enter them in the chat box and we'll relay them to the presenters. Dr. Mayorga, thank you. Please take it away.
Thank you. That was a very nice introduction. I will share my screen and then I'll make sure that it's on presentation view here. It says I need participant sharing ability.
I think I just gave you that. You should be able to try again.
Okay. Okay, are you seeing the slideshow?
Yep,
Great.
looks great.
Wonderful. Thank you. So as was mentioned, I'm at NC State in the Department of Industrial and Systems Engineering, and COVE-SIM is a group of researchers from several schools, and I'll mention why ECU got added later. Why Georgia Tech is involved. One of our colleagues used to be at Georgia Tech, and she's now at NC State and was actually on loan to the CDC with H1N1 pandemic, so her expertise is very important to us. So specifically, I'm going to talk about the projections that we have done for schools, but COVE-SIM in general is about modeling any sort of intervention for COVID, and other work that might be of interest to this group is also about equity associated with the rollout of the vaccine. And what I hope at the end to convey is not just about the results, but if you all have any ideas of questions you're wondering about or things you're not sure what would be the impact of certain interventions, our team can respond by creating models specifically to answer those questions. Okay, so as I mentioned, the team is modeling SARS-CoV-2 infection outcomes, including deaths and hospitalization. And part of the group is also working local stakeholders, so interviewing stakeholders to try to understand how they might use decision models, but also to understand what we could inform for them. And so that's how this work came out. And our team at UNC, when they were speaking with the local health, this was several months ago, they started alerting us to the question of, the school boards are asking, what should we do in the fall? And so we looked into answering that question. So for this presentation specifically, I'm going to talk about our estimates of the proportion of susceptible students that would become infected throughout a school semester, depending on certain variables, such as the incoming level of protection. So what that means is which
Hey, Dr. Bayogra, I'm so sorry to interrupt you. Your audio is going in and out a little bit. So I'm not sure if it's the internet connection or the audio device.
I'm going to switch off the Bluetooth to the computer.
Can you hear me now?
Yeah, that's better. Stay close to the microphone and I think we'll be able to hear you. Thank you so much.
All right, you might get a big face then. Were you able to hear up to that point or?
Yeah, keep going.
Okay, sounds good. So by incoming level of protection, we mean students who may have either had a vaccine or had COVID before, and then testing different masking and policies of randomized testing, such as PCR test or antibody. Okay, so I'm going to talk about a hypothetical scenario. We're working right now on a dashboard where users can go in and change information about their school and see what the results would be like for their particular school. So we started with a population of 500 students, and we were trying to be very conservative in our estimates. So we would say that at the beginning of the semester, you have 2 to 3 students that are infected with COVID and you don't know it at the start of the semester. We also assume that students might bring in an outside infection. This could be from attending birthday parties or going to church or in sports, for example. So these will be infections that would be brought in from the outside, not within the school. And then we also look at policies of randomized testing and isolation. So you've probably heard about R0 or the transmissibility of COVID, and we assume a very conservative estimate. The Delta variant is twice as infective as Alpha variant, which is twice as infective as the original COVID strain. But there were concerns when we spoke to some of the local health departments and school boards that, there's this idea that children are not as infective as adults. So just to be conservative, we use an estimate of 4. Most research estimates from 5 to 8 as the infectivity of the Delta variant. And then we assume that masks reduce infectivity by 50%. This is also conservative. The research varies on this. Some masks can reduce infectivity up to 75% if they're high quality masks, such as N95 or KN95. But we don't know which mask students are wearing, and we also don't know if students are wearing their mask correctly, right? Sometimes they let the mask slide under their nose, and they also take the mask off to eat. So that's the reduction of infectivity for masks. We do, though, assume high compliance with isolation if a student gets a positive test, and then they will go home and isolate for 10 days. We also have a very well-mixed environment. So this is a regular school setting. There's not any specific effort to cohort the students. And so I'll talk about the implications of that later. So we think about different settings, right? If students in high school have the option to get the vaccine and may have more higher vaccination rate than a middle school setting. Whereas in an elementary school setting, the students do not have the option to get the vaccine. So incoming protection of 30% would be that 30% of the students have already have COVID. This varies, but this estimate was based on one of the counties that we were working with where they had information about previous infections. And actually, if you look at the reported cases from the NC dashboard, this is in line with the state level estimate because we assume that there is an underreporting of cases, 3 to 4 times underreporting. So I'm going to first show you how to read the chart before I go into the results. So on the bottom of the chart, what you're going to see is time. So at the beginning of the semester is time 0, and then you have 107 days in the semester. And then on the y-axis, what you see is the proportion of susceptible students that are infected. So these are students who had not previously had the virus and have not been vaccinated and then become infected over time. And then the lines represent different scenarios. So focusing on the different settings, what we see is the top 2 lines is the effect of no masking, where the purple line is if we do randomized PCR testing. So that would mean that you test 50% of your school weekly. And as you can see, they are pretty high. So let's zoom in on some of these. Oh, and the lower ones are with masking, but I want to zoom in so that we can look at it. So let's take the middle school setting, for example. So in the middle school setting, if you do nothing and also just let them stay in school and don't go to virtual school or stop in the middle of the semester, by the end of the semester, you have about 87% of students that had not previously contracted the virus would contract the virus if you have no masking and no testing. You could reduce that some and get below 75% if you do randomized testing, but clearly that's not acceptable. But if you were to implement universal masking within the school, even without randomized testing, you could get this number down to about 30%. And if you further implemented randomized testing, you could get that down to 15% of students. And what does that mean? Of course, I don't think that we would go into a school setting and let 95% of students or 90% of students get infected. So you would probably end up having to do something at some point in time. So in here, within 2 months, you have 80% of students infected. And then you would reduce that with masking and further reduce that with testing. If we go back to our hypothetical school scenario, what does that mean in terms of the number of students, the number of new infections? So you see that if we do nothing, you have 260 new infections. That's over half of the school. But if you were to do masking, which is this third one, masking alone, even without testing, you could reduce that to 105. And if you were to implement both strategies, masking and testing, you could get that down to 49 students. So what do all of these numbers mean? First, as we already know, the Delta variant is very infectious. Kids under 12 still do not have the option to receive the vaccine, so they remain unprotected. And without masking, we would have a very high number of students that are susceptible becoming infected, especially in the lower schools and in the elementary schools where they do not have the option to vaccinate. But masking and testing in combination could reduce this further. We've also done some sensitivity analysis to the masking. And if you can get high quality, well-fitting masks, then you can reduce this even further. So I've been using the tagline mask up or go virtual. And I think that we've seen that repeatedly in or close the school, as we've seen in Georgia and in South Carolina and in Florida and a lot of other places. And you know what I also want to say is that this is not a model outside of the school. So there are many implications of the infections that happen within the schools. Sure, maybe our kids will recover, but some kids will then go out and infect individuals within the community, such as elderly grandparents and other family members. Also, there's days of school absences. The quarantine period is at 10 days, I believe. And so this is difficult, forcing caregivers to take time off of work And the schools are not requiring to have a virtual setting. They require to have availability right now of the work outside of the school, but the kids are not necessarily going to school while they're out. And then, of course, there are some potential implications for children that obtain COVID. And however, we want to keep our kids in school. I do not believe that shutting schools down completely is, or having only virtual learning is the solution, because as we know, there's many benefits of being in person in school. So that is what I have today. I have some additional slides if there are questions. And one thing also that I want to give away, add here is there's more that can be done. I have not included in the model filtration systems or efforts to improve air quality. The model does not include cohorting so that you could separate the classrooms, making sure that the grades are not mixing. And there could also be contact tracing that would be included. That's not included right now. So we could get the numbers down even further, but we saw that the line from masking to no masking was very pronounced, right, from the top to the bottom. So I'll stop and take questions.
Thank you, Dr. Mayorga. I know that when I saw this information come out, I guess a couple of weeks ago, it certainly was very stark and eye-opening for me, and I know many others as well. I believe we were going to go on to our second presenter now, and then we're going to have our questions, and I know there will be some questions for you that we'll loop back to. So now I would like to once again introduce Dr. Kalu, who is going to share her information with us. Thank you. Take it away.
So I always lose my control as soon as I share my screen. But thank you so much for having me here today, and thank you for not just having the opportunity to talk through some of our work, but really to show our gratitude, because our ability to do this work in North Carolina largely relied on child advocates across the board. So some of you are frontline educators, some people are within the legal system or the legislative system, and it's all played a part. So thank you for that. Let's see if this will work in my favor. So this has already kind of been gone through, so I will keep it relatively short. I think Adam highlighted that I have a few roles here, but I'm coming to describe our efforts within the ABC Science Collaborative, funded by the NIH, but involves work from both UNC and Duke. We do collaborate outside of the basketball field. So for those that may know others within the Duke system, these are just a quick snapshot of people that have been involved, and I've spoken about our data in all of the different settings. All right, so just going straight to what we were doing and what we have found in the last probably about 15 months now with working with schools. So what we know so far is that planning and protocols work. And the advantage with the school system is the school is that unique place that has to do with planning curriculums and planning for students and staff. So having this multi-layered approach to preventing COVID-19 would actually work in the school system. So what's a protocol? It's just official procedures, systems, or rules. And with COVID, we may argue about masking and ventilation and all those things, but the biggest point we've learned is that COVID prevention is not based on one single intervention. It's sort of that multi-layered approach. And if you can stagger those layers appropriately, the holes don't line up and you don't get COVID, so this person at the end doesn't get COVID. I always like to point out this tiny little mouse here. So this is a slice juice model. As this mouse is the mouse of misinformation or disinformation. And despite all our layered approaches, if you get that mice going all the way through, we can kind of chew through all this because people don't believe in something or don't actually practice it as intended. So all of these factors only work if we're doing them as intended. And then just finishing up with pointing out personal versus shared responsibilities. We are in a community setting and COVID has affected us all. So certainly looking at our ways to solve COVID as a shared responsibility may actually take us further. We started working with schools as far back as June, July 2020. And the initial questions just revolved around the length of school closure and what are ways in which we can use what we understand about SARS-CoV-2, the virus that causes COVID-19, to inform reopening of schools. If people remember, at that point, schools were completely shut down. Where by definition, our day-to-day jobs involve just trying to get data. And within the United States, we either had sort of two extremes where people opened up without any mitigation process in place, or people shut down completely with no plan for how to open up. So as we headed into the fall months, we worked with some key districts, we call them the 11 ABC districts, to track how often SARS-CoV-2 infections or COVID-19 infections were happening. But I think more importantly, we wanted to track what was happening within the school setting. We knew that COVID was happening in the community, and if people come into schools with COVID-19, there was a potential for spread. But how often were we seeing spread? And so these stellar leaders, because they did a lot of work, especially when we didn't really know much, they worked with local health departments to figure out secondary transmission, and which just translates to within school spread. And there was also a lot of coordinated community learning, as we just provided a platform for superintendents and operational leaders to meet weekly with some ABC faculty members to review lessons learned and come up with standard prevention methods. So what did we find from the fall of 2020? This graph just shows on my left, looking at the screen, kind of the y-axis, the cases per student or residents per week. And then the x-axis is showing the dates, but just kind of focusing on the pattern of and I think I have a slide that goes through the specifics. When we look at what's happening across all North Carolina counties, we saw that there was kind of an ebb and flow in the cases per student, kind of went up and went down. That's just reflecting community infections. But within the study districts, we also saw that ebb and flow. And this is important because people expected that when we saw spikes in the community, we would immediately see spikes in schools. We will see more people coming to schools, but the question was, are we going to see spikes within the school setting? What we found, I think I actually lost the slide here, but it's okay. I can kind of go through. But what we found was, we found about 800, just under 800 infections or people with infections came into the school setting. And on average, North Carolina residents were infected with SARS-CoV-2. Sorry, let me take a step back. So of the people that we were looking at, once they came into school, we had about 800 or so infected people coming to the school setting, but they only infected less than 1% of their close contacts. So we saw very low within school infections, despite community infections coming into the school setting. And at that time, what were people doing? Just as a reminder, there were no major overhauls of the ventilation system. We actually didn't have within school testing. And they had some screening processes. They had people at 6 feet distance in the classroom. But other than that, there was not a ton of things being done. So the second point here is just enforcing basic mitigation policies, such as masking, in the fall, distancing, hand hygiene, led to minimal clusters of SARS-CoV-2 infection and diminished within school spread without increasing the community infections. Community infections kind of did their ebb and flow. So you kind of refuted that hypothesis that if you just open schools up, we're going to see huge super spreading events and shut down the community. We showed in the fall of 2020 that that wasn't the case. But questions continued. So learning from the fall of 2020, we did work with superintendents to come up with about 12 key principles. I'm not going to go through all of them. I did provide the slides at the end. But focusing on the first 4, the key points were for school districts to be transparent, have some clear roadmap for knowing who's infected, who needs to be traced, and then developing a dashboard that's publicly available, because that did help to reassure local communities. And of course, learning from experience and implementing lessons learned. There were a few other principles that had to do with pandemic fatigue and some special situations, including our children that have special needs that may not be able to wear masking. And we kind of have worked with educators to come up with plans for those settings, because they are higher risk settings for COVID-19 spread. We also looked outside of North Carolina, and as you all may remember, we started to see more and more data similar to this. This came from the CDC that looked at children with COVID-19 infection, and they found that despite school being open in the fall, coming into the spring, when they looked at the tracing data from children that were infected, most often they were more likely to have attended weddings and parties and play dates as compared to attending school in person. Just kind of furthering that concept that school by itself can be a safe place for in-person learning. Well, just by that data, we hit a surge, and we're all hoping that we're not going to repeat the same thing in 2021. But we had holidays build up on each other. We had a lot of close contact and just increased infections in our local community. And so the initial question was, you have data from the fall. We were not seeing as many cases. As we're hitting the winter surge, is it going to be different? Is this going to play out differently in school? So we went back to the group we're working with. And as a reminder, the CDC at this time continued to say that if the community rates have gone up, schools should really remain closed completely because they expected that schools would drive infections. And so we just tracked cases from October into February and looked at within school spread, which is often referred to as secondary cases or secondary transmission in our papers. And what did we find? Again, focusing on the graph here, we're looking at cases per 1,000 people. The straight line is looking at community case rates. So we expected a surge, we saw a surge. Primary cases just means people were infected and they came into school. That's not shocking. If you live within a community, schools are just a reflection of the community. People infected will come into schools. But the teal colored dots here are what's most important, which is secondary or within school spread. In the fall of 2020, in the spring of 2021, we continue to see really low rates of within school spread, just allowing us the opportunity to use data from schools to make decisions. So in conclusion, what did we find from the spring of 2021? If basic mitigation strategies, and I like that I'm sort of going after Dr. Mayoga because she did highlight some things that can help us with projecting the future. We looked at sort of at the moment, what's going on in schools and retrospectively, so looking back, what happened? And schools used fairly basic mitigation strategies and showed very low within school spread, despite our communities having high rates and really high rates of infections and hospitalizations in the spring. A little bit of concern around CDC guidance because it still was misapplied. And so we worked a lot with the CDC to see if we can update some of the guidance. It failed to take into account some of the real life challenges that I know a lot of school leaders have had to deal with, including when and how to improve ventilation, what happens with transportation, and what's happening with sports and other extracurricular activities. My last couple of slides actually switch gears completely to focus on what a lot of the advocates in North Carolina did. So I know people somewhat hesitate, they would prefer to have voluntary submission of data, ultimately for a number of reasons. School districts, per the law that was signed, per the bill that was signed into law, were strongly encouraged, rather required to submit their data, and we reviewed their data and submitted it back to our legislators over time. So what they're done with the required submission at this point. But based on that law, we had 100 school districts in North Carolina provide their data on SARS-CoV-2 infections, so COVID-19 infections and spread. And I just want to highlight a few key points that we learned from practical real-life data within our state. So in total, there were 115 local education agencies, but it's essentially the school districts or charter schools. And the numbers here just reflect how many elementary, middle, high schoolers, staff, and teachers, so staff included those that were not within the school. We wanted to know what was happening, say, on the bus or in the cafeteria, for example. So a large number, I think in the end, is over nearly 1 million people involved with all of this in terms of all of those that we were tracking. And then a few tables can get busy with numbers. I have some red boxes to highlight the key point. Again, cases in communities would mean cases in schools. What we were looking at was secondary cases within school spread. And just focus on the numeric values here. The percentages were all the same, but cases came into schools. This is just looking as a whole on all of the schools that participated, regardless of small, medium, or large districts. Very low rates of secondary within school spread. This was regardless of the bus practice, either put in one person, two people, or three people on a seat, we still saw fairly similar numbers across the board, such as low rates of within school or school-associated spread. Similarly, distancing is a huge issue, so less than 3 feet, 3 feet or greater than 6 feet within the classroom, low rates of within school spread. So across the board, all of this was consistent. If schools followed through with masking, when they could tracing and pulling out people that were visibly ill. But despite knowing all of the low rates of within school spread, it's just kind of important to look at what's happening with quarantine numbers. We still had nearly over 40,000 students and staff that were quarantined, and it's not clear if this is actually truly preventing further infection or if we're over quarantining. And I know they've modified the guidance for this year going forward. And the final point was that just North Carolina schools are doing a great job. They've prevented COVID transmission in schools to the best of their ability, and continuing some of those things will help even with a highly transmissible variant. We've said this in different settings. We still get a ton of pushback about the practicality of applying some of those things, but I think almost without a shadow of doubt, I have this slide that just summarizes the cases. As we continue to see the low attack rate of within school transmission, particularly in North Carolina, we can support the fact that wearing masks are really effective in preventing within school spread. And really, there's no distance with the 3 versus 6 feet, but if kids are on masks, it's probably better to space them out a lot more or take them outdoors. And then quarantine guidelines were probably causing more harm than good, especially if we could increase testing, which has now been done. I have 2 slides on this. I wanted to provide this more as a resource. The question that's often posed to us now due to just masking battles is, are masks still effective in schools? And this would just repeat the point I've made for the last couple of minutes, which is in North Carolina, at least we've seen masks are very effective in preventing spread, but it's not just about us. We looked at other states and we have researchers that have looked through this as well, and they've shown the same result. Less than 1% of within school spread when masking is used. To counter that, you can look at what's happening when masking is not used. And yes, there are a lot of sentences on here. I won't go through all of them, just pointing out kind of what's bolded. If you're seeing less than 1% of within school spread in masked environments, unmasked environments, you could see up to a third of people exposed get COVID-19. And this was before the Delta variant. So presumably this would be a lot worse right now. And that's why the conversation around return to school has really revolved around masking, because we're expecting that Delta variant is 40 to 60% more transmissible, especially in adults. And although we know that kids spread COVID-19 less, they're fully capable of spreading this infection, getting sick, and having post-COVID complications. And so our best data suggests that unmasked environments can have high rates of COVID-19 spread. And we have data from Florida, from Georgia to support that. Just the last point on the slide is the extracurricular activities pose a unique risk. And it's really been hard to quantify what that means. We know that our kids have gone through a lot in the past year, and it's hard to imagine that we should limit them from participation in sports and other extracurricular activities. But things like wrestling and basketball have been associated with higher rates of spread and may be hard to wear a mask in those settings. And so testing has become one way to mitigate spread. I think my take-home point here are just that we know from data from North Carolina schools that masking is effective. Despite full in-person instruction, across all grades, we still saw low rates of spread when masking was in place. You can have full capacity bus transportation, and quarantine rules can be better, which at the time of our talk today, they are now better. We have modified quarantine rules for school settings. And then schools, of course, should evaluate their safety protocols around extracurricular activities and athletics. So I will wrap up here, and I can leave the slide up or I can take it down so we can just answer some questions. I did not focus on vaccination. A lot of our data occurred in the setting of only adults having access to vaccination, but now that we have an EUA for kids, we certainly expect that higher vaccination rates will lower spread. But it ultimately may depend on a few things, including how transmissible Delta variant is and if people continue to adhere to proper masking. thank you so much for your attention today, and I'm sure there are questions I can help address.
Thank you so much, Dr. Kalu and Dr. Mayorga. Once again, we really appreciate this in-depth information. And before we kick it over to the questions, I mean, I must say the thing that just, keeps blaring at me through this is masks work, and that it's imperative that we have our children wearing masks in schools. Fortunately, that there is mandatory masks for the vast majority of our students as of right now across the state of North Carolina. I think over 85% of our state students are in school districts where there is these mandatory mask mandates. We hope that that stays in place as long as it takes, and that some of the other school boards that have chosen to go optional will reconsider that. And that's NC Child speaking there. So I know, but now I want to turn it over because I'm sure we have some questions from folks.
Yeah, I'll go through the questions. And I think that Dr. Kalu and Dr. Mayorga have actually addressed a lot of them in the course of these great presentations, but lots of different people are asking about the severity of COVID in children. Why does this really matter? Maybe kids aren't affected so much, and I'm wondering if either of you would like to address that and talk about that for just a second.
I'm not an MD, so I'll hand that over to Dr. Kalu.
It's totally fine. I think we can all kind of weigh in on what we've seen and just what we've experienced. But what the data shows is SARS-CoV-2 certainly infected kids less, so all kids were just less efficient at spreading it. However, we have seen severe cases, either due to some kids that have risk factors, and I can kind of talk through what that looks like, and SARS-CoV-2 or COVID-19 infections function at a level of community spread. So even if kids are less efficient at spreading, if we continue to see infections within kids who, as of today, are most likely to be unvaccinated because we don't have a vaccine authorized for less than 12, we expect that this will continue to spread and can cause even worse complications in adults. So kids can spread to each other, kids can spread to adults, lower cases in kids, but I cannot just dismiss even a child that dies from this. I know people have said case rates are low, death rates are low as compared to adults. I work with kids every day. I have kids in my family and all of that. So I don't use that as a decision or as a data point to not support ways to prevent infections in kids. If we leave kids as this susceptible pool where they're not vaccinated and can continue to get infected, we cannot expect to eliminate this from the rest of our community.
Thanks so much. I think we're just going to hit one more question because we've still got more to go in this meeting. But one other question I think is really important from Robin. Can you both tell us about how this information has been shared with elected officials, school board leaders, other folks who are making these decisions?
From our end, partly because the most recent data was directly linked to North Carolina law. We just fed it all the way back to that. And we've worked with all school districts across the state. I didn't have the chat up while I was speaking, but I think I saw a question about rural versus urban. Essentially, in North Carolina, we've gone all the way across the board, from the beach to the mountains. And so we've worked with every group across the state and shared that feedback back to all of our legislators, and also shared it across school leadership. I'll defer to Dr. Mayorga for the CoVSIM data.
Yes, so in speaking with the local health departments from around the state, like you said, all parts of the state, they had requested information. And so we presented that to them, and then they presented that themselves either to the school boards and or had us present to them. It didn't always result in a, this was during when the decisions were being made about masking, it didn't always result in a masking mandate, but at least the information was presented to them. And the other thing is that, I know this is about North Carolina, but this is a global problem. So we've also been presenting in other settings like Speak Up America and to people who contact us through our website as well.
Great. Thank you both so much. This is really has been great and super informative. And I wish that we had a lot more time to discuss with you too, this great research. So thank you both so much, and hope that you can come back again. But I know you also are busy talking to anyone and everyone else that you can about this. So thank you very much.
Thank you for having us.
Thank you.
Thank you. And now, last but not least, of course, with our speakers, we're going to turn it over to Tiffany Gladney, who is the NC Child Policy Director, and she's going to give us an update about what's going on legislatively these days. Tiffany?
Thanks, Adam, and happy Friday, y'all. This week, although it seems like budget negotiations are stalling a tad bit, and there's a little bit of disagreement going on between the chambers, we did actually see a lot of bills move this week. Particularly, Senate Bill 35 was signed into law yesterday. This is the bill that would end child marriage, or at least raise the age for child marriage in North Carolina. So there were some highlights in the week too. So on the early childhood education, child care forefront, we saw Senate Bill 570 move, and this is a proposal that would hold child care facilities harmless on environmental ratings should staffing shortages affect their star rating. The bill passed the House Tuesday, August 24th, and is now on the governor's desk. And on the child welfare and safety forefront, we saw Senate Bill 35 get signed into law. Tom V and I were privileged enough to be at the governor's mansion for the signing ceremony. This new law would raise the minimum age to marry from 14 to 16, and also create a 4-year age difference limit for adults who are seeking to marry a 16 or 17-year-old. We saw Senate Bill 693 also move. This is legislation that would make various updates and amendments to the juvenile code regarding abuse, neglect, and dependency laws. So some of the changes would include directing the Department of Social Services to identify and notify adult relatives of a juvenile when with legal custody of one of the juvenile siblings. Authorize the court to consider placement of a juvenile with non-relative kin, if not with a relative, and provide that a positive drug test alone is insufficient to deny a parental visitation. So after passing in the Senate in May, Senate Bill 693 picked up some additions in the House, including provisions from House Bill 205, the Abuse and Neglect Resources in Public Schools bill. And this bill would require public schools to post information and a reporting phone number for students with information on child abuse and neglect, including sexual abuse. We also saw that a freestanding bill, which among other things would allow legislators to review individual DSS records, made its way into 693. So this bill passed the Senate Tuesday and is now on Governor Cooper's desk awaiting his signature. And then there's House Bill 769, the Foster Parents Bill of Rights. This bill recognizes a list of rights for foster parents, including the ability to serve as a respected member of the child welfare team, receive specified information about the responsibilities of foster parents, and access to support services, including active participation in the decision-making process regarding the child. This bill passed the Senate Thursday and will return to the House for a concurrence vote, more than likely next week. So on the juvenile justice forefront, we saw Senate Bill 207 move. This comes from the recommendations of the Juvenile Justice Advisory Committee. This bill seeks to modify certain provisions of the Juvenile Justice Reinvestment Act. So it includes clarifying the amount of time teenagers can serve in youth development centers, clarifies that juveniles can be held in holdover centers before heading to adult corrections facilities, and allows juvenile court counselors to conduct child consultations and investigate complaints for children ages 6 to 9 who have been referred to the juvenile justice system. So this bill did stall for months in the House, but it moved quickly through the committees last week and passed the Senate this week, and is now also on Governor Cooper's desk. And lastly, on the health forefront, House Bill 608, Dignity for Women Who Are Incarcerated, saw some movement this week. This is the legislation that aims to provide reasonable accommodations for pregnant inmates, including prohibiting shackling of inmates when in labor, and also provide necessary postpartum care. So it cleared the Senate yesterday and is now headed back to the House for concurrence vote. So with that, I'll hand it back to you, Adam.
Thanks so much, Tiffany. A lot going on this week related to kids, even though the budget wasn't moving necessarily. So appreciate that update. And, again, to reiterate about the raise the minimum age juvenile justice bill, means now in North Carolina, it effectively means that only very few children under the age 10 would be prosecuted in the juvenile justice system. We have effectively raised the minimum age up to 10, more or less. And of course, a few years ago, we raised the age to keep juveniles in at the upper end, 16 and 17-year-olds. So, it was years and years, and lo and behold, here we have a couple-year period, and a lot of reforms are getting done. So bipartisan too, which is always good to see. Fawn, do we have any other questions or anything?
I'm seeing some hand claps and write-ons about child marriage and juvenile justice, and I think that's great. Just because we have a minute, I'm going to share real quick a slide about local school district policies on optional masking. So I know this is something that folks are following. If you're in any of these counties, then your school district still has an optional mask policy. Hold on, there's more. Here's the next slide. So there are about 25 local school boards that still have local mask policies. And when you get our follow-up email that comes out today, it will include more information about this if you want to reach out to your school board members. Some of these school districts are revisiting this decision every 2 weeks. Some of them are revisiting every month. We've seen lots of school boards change their minds. I think almost 50 school boards, change their policies from mask optional to mask required. But people are, of course, tired of wearing masks and tired of sending their kids to school in masks. And so you're going to see these decisions coming continually. So if you're in these school districts, keep an eye on this and communicate with your school board members. If you're in one of the many districts that flipped and changed its mind, you need to understand the incredible amount of political pressure that is on your local school board members around these decisions. These people are volunteers. They don't have personal security details, and yet they are dealing with some real angry constituents about this. So thank them, send them some love, send a letter to your local newspaper thanking them for what they're doing if they're putting the science first, because that's really what I think what these presentations have gotten across today. A lot of strong emotions and opinions on both sides, but we need to follow the science in public health, right? And if that's what they're doing, then they need to be thanked and honored for that. So just wanted to make my pitch on that. And then wanted to also share upcoming meetings. We won't have a meeting on Labor Day, a live meeting. Tiffany will send you a written update as always, but that's Labor Day weekend, so we're giving y'all a break. But on September 10th, come back. If you have questions about kids and COVID and transmissibility, Delta variant, severity, death rates, all that scary stuff, it'll be great. We're going to have our state epidemiologist, Dr. Zach Moore, will be on, and Dr. Kelly Kemple, she runs the Women's and Children's Health section at the Division of Public Health. So they'll be able to answer all your questions about kids and COVID and Delta variant. So hope you can make it. It'll be a great meeting to attend. And I'm going to look again in the chat to see if anything else has come up. Oh, and Melissa, I would love to have you talk about the support that Long COVID Kids is providing. So I won't put you on the spot right this second, but let's talk about that, because it's a wonderful support group for folks who are dealing with that issue. Okay, I think that's everything. And we have a school board member, I think, in the chat, Mr. Tedesco, who has raised a lot of scientific questions about COVID. And I would like to connect you specifically with our experts if possible, so that you can get your questions answered more directly, because I think we could spend 2 more hours here doing that. So thank you very much, everybody. And Mr. Tedesco, I would love to follow up with you if you want to shoot me your email address in the private chat. I'll stay on the line for that. Anybody else? Questions, comments?
I just wanted to say real quick as well, and we'll try to get a slide in on it, or maybe we could send it out as part of the follow-up, but Prevent Child Abuse North Carolina, the North Carolina Collaborative for Children, Youth, and Families, NC Child's helping out, and some other groups, they're doing a 4-part virtual Policy Institute series starting in September. I think it's like September 14th, September 28th, October 5th, October 12th. And so these are like morning long institutes, and they're going to have guest speakers. They're going to be talking, and they're going to be focused on different levels of advocacy. So the first one's talking about like coalition building. Then we're talking about local advocacy, state advocacy, federal advocacy. They led this series last year, this virtual series, and it was real successful. And we had legislators on and other speakers. And it's shaping up really well again. So we'll help get the word out on that, and hope that folks can spread the word within your networks and tune into those this fall as well. Any other announcements?
I did see one question, I'm sorry, from Richard about the school. No, I'm sorry, about the I think it's Senate Bill 207, the star rating bill, Tiffany. So we can, but there'll be more information in the written follow-up that we send out, Richard. So I apologize, I can't find it right now.
All right. So with that, I hope everyone has a wonderful rest of the day and weekend. Stay safe, and let us know if you have any questions or concerns. And we will see you in 2 weeks on a Friday call once again. Bye.